Our next speaker comes to us from Westchester, New York. Jerry Wishner, one of my favorite speakers. He's going to talk about the economics of things, and it's so fun to hear him talk because his pathway and my pathway are so similar. And we arrived at all the same conclusions, had all the same fights with administration. It's really fun to listen to him talk. So he is colorectal trained, but also does general surgery, and the robot has kind of changed some of his practice more towards general surgery, but I'll let him talk about that. So take it away, Jerry.
Good morning from Westchester County, New York. I certainly hope everybody and their families are doing well today. This morning, I'd like to share with you my experience transitioning from a minimally invasive surgeon to a total practice robotic surgeon, talking a bit about some of the data, both clinical and financial, that we were able to collect along the way. Just a bit about my background. I graduated from medical school in 1988, which in many respects I think was the perfect time to become a general surgeon because we learned how to do open surgery beginning of my residency. Somewhere along the middle is when minimally invasive laparoscopic surgery was really developed and evolved, as we all know, very rapidly. And I decided that's what I wanted to pursue as the focus of my career moving forward. There weren't a lot of minimally invasive fellowships back at the time, so I did a fellowship in colorectal surgery in Baltimore at the program that at the time had the highest volume of laparoscopic colon surgery. 1 year later, I went to Virginia to do a minimally invasive surgery fellowship. I think there were probably twice as many minimally invasive surgery fellowships in that 1 year's time. They were really kind of popping up all over the country, so trained surgeons could learn how to do MIS at that point. I came back to New York in 1995. We set up a minimally invasive surgery program. We had a colorectal program as well, training fellows in both the whole gamut of surgery with a focus on minimally invasive surgery at that point. In 2006, I moved to Northern Westchester Hospital, where I currently am. I was doing approximately 450 cases a year at the time. 85+% of my practice was minimally invasive, and I honestly had no role or no interest in minimally invasive robotic surgery. When I came to my hospital in 2006, the hospital did not have a robot. At that point, the urologist and the GYN oncologist were the ones really pushing to get a robot for the hospital. When they heard there was a minimally invasive surgeon coming, they tried to enlist me. You know, the more people who go to administration and tell them they need to do something, they thought the better chance they had. My CEO, who actually just retired this year, approached me in 2006. And my exact response to him was, I swear to God, I will retire before robotics ever penetrates into general surgery. So I really was a skeptic, to say the least, back in 2006. In 2012, I did my first robotic case. I remember going to do a case observation and looking in the surgeon's console over the surgeon's shoulder, and the visualization alone just blew me away. I couldn't believe how well you could see. I would almost make the argument at that point that if the visualization was the only thing the robot brought to the table, it would be worth it. But as we all know, there's so much more. I've done approximately 2,000 robotic cases to date, colorectal still being the large volume of my practice, although while that number continues to rise, the hernia really is taking over a much higher percentage of my volume, as that seems to be the rate of growth is outstripping the rate of growth in the other areas. Now, just to show you how I did it, I kind of did it backwards. I started doing gallbladder surgery in 2012 and complex left-sided surgery, mainly single-site gallbladder, APR, and LARs. I didn't think there was a role for right colons. I didn't think there was a role for ventral hernias. I certainly didn't think there was a role for intracorporeal anastomosis, and I was never going to do an inguinal hernia robotically. And it took me about 2 years to become a total practice all-in surgeon, and I just kind of want to share with you what I learned and how I evolved along the way. To do that, I would tell you I think I did this backwards. I think if I could do it again, I probably would start with hernias and gallbladders. I'd start with some of these index cases that were a little easier to do, kind of build a foundation here at the bottom. I think there are many benefits to that. Number one, you have a higher volume of cases to do. So not only are you getting experience, but your team is going to get experience. They're going to get experience setting up the room. They're going to get experience turning over the room. If you start out with colons or paraesophageal hernias, it's hard to do more than one in a day. But if you start out with these index cases, you can then branch out, as we see, whether you'd want to branch out into colectomies, if foregut surgery is your thing, sleeve gastrectomy, gastric bypass for our bariatric colleagues. It's really ideal, I think, to kind of build a steady foundation with cases you can do in a higher volume that tend to be cases of lower risk. This really should be the last slide in my program. Worry not, I have plenty more slides to share with you. Just the story kind of ends and begins here at my hospital. This is Northern Westchester Hospital. We're about 100 years old. We're approximately 250 beds. There are 6 area community hospitals similar in size to us within approximately a 20-mile radius. That would be our competition, if you will. We're about 40 miles north of New York City, and certainly the city hospitals, the big medical centers in New York City, are happy to steal as many of our patients away as possible. We have 11 operating rooms. In 2006, again, unrelated to me because I wasn't interested, but the hospital got their first robot, the Vinci S. In 2012, when I began to start doing robotic general and colorectal surgery, we needed a new system. We got the Vinci SI, and we jumped on the vessel sealer as soon as it came out, the stapler, single-site Firefly. We were kind of all in on the technology. In 2012, that same year, we set up our steering committee. IRMA stands for the Institute for Robotic and Minimally Invasive Surgery. We have representation from all disciplines that are interested in robotics, and we'll talk a bit more about that. We got our first XI in 2014 when it came out. We swapped out the S, so at this point we had an SI and an XI system. Jumped on table motion. We had one of the first tables in the country that were available to us. We became a center of excellence with the Surgical Review Corporation. We got our second Vinci XI in 2019, and we got our third system just last year. So to summarize, we're a small community hospital with 11 operating rooms, and 3 of them have Da Vinci XI robots that are fully loaded, table motion, and all the bells and whistles. And the only reason the hospital is doing that is because we were able to learn that not only is this clinically beneficial to our patients, but it's also financially beneficial. And let me talk a little bit about how we were able to do that. In order to be successful, you simply have to build a program. It's really as straightforward as that. For any surgeons in the room who think the robot's a great idea, you may think it's the best thing since the scalpel to happen to surgery. If your hospital's not on board, it's just not going to work out. Talk about the leaders in the hospital, and you need a physician, obviously, and that could really be anyone here in the room, or you can identify colleagues at your hospital who share your vision. We need a hospital. And we need corporate support. Intuitive has been tremendously helpful to us through various programs that I was able to go to, that my hospital leadership was able to go to. They sent the Genesis team to our hospital early on to help us become more efficient, and they have a tremendous number of resources that you can take advantage of. Certainly within the hospital, again, it all starts with a physician, but we need to build out from that. And the first thing I looked for was an administrative champion. And at our hospital, this was one of the vice presidents in charge of service line development who, understood from the very beginning what robotic program really could mean to our community, to our patients, and to our hospital. We also identified a nursing champion. In this case, it was the director of surgical services, who was an RN, but really in charge of the OR and all perioperative services. You just look at this kind of chart of some of the organizational challenges. I'm sure you can see that many, if not all of these issues will come up at your hospital, be it block time, volume, staffing, technology acquisition, when to buy new systems, and so forth. We kind of looked at efficiencies as a team. If you want to have an efficient procedure, certainly you need an efficient surgeon, but you also need an efficient OR team. And we thought it was very important early on that we try to keep the teams together as much as possible, and then kind of add and rotate people in to the team as we became more efficient and as we kind of stabilized our point in the learning curve. We looked at all sorts of different things. When you look at an efficient team, right, there's room staffing, as we talked about, right, consistent team, staff breaks, right, our staff, we're very specific in when people take breaks. We don't want them taking breaks when it's time to turn over or set up the room. We don't want them taking breaks when we're getting ready to do a hand-sewn anastomosis. We find that by making sure the main team is there at the critical points of the day, we became significantly more efficient. We'll talk a little bit about an XI versus an SI. One of the nice things about an XI robot, it stays in pretty much the same place all the time, and I'll talk about that in some of my talks later on as well. room turnover, how to set up the trays, instrument storage, cleaning, and reprocessing. By building a team and by bringing all the folks necessary into the discussion, we were able to build an efficient program. This is the hernia data. This is actually my first 500 robotic hernias. These are all unilateral hernias. The bilaterals are separate. And you can see here that the first cases took about an hour. This is the skin-to-skin time, the first 25 cases, and we slowly came down. Now, again, that may not be a fantastic time, but that's certainly not a crushing time that's going to ruin your entire day and ruin the entire OR. And as we came down and as we kind of leveled off, for the last 300 cases or so, we are sitting at almost exactly 30 minutes, and that's a skin-to-skin time on our hernias. And we can see the other times. This is the consult time, kind of mirrored that. The mobilization time, the patch placement time, closure of the peritoneum. All these times kind of came down reproducibly, and everything leveled off at approximately the same time. Initially, we tracked all these numbers, and I tracked this data, to learn clinically and to be honest with myself about how I was doing and look for areas where I could improve and look for places to make things better. But what we also realized kind of a little later in the game is that you can draw a lot of economic information out of this data as well. And in many respects, it frustrates me to even think about the economics of it. I think as physicians, sometimes it's challenging just to think about what the right medicine is. But we have to think about the cost as well. And I think we have to do that because if we believe this is appropriate and this is better for our patients, we have to understand the finances well enough that we can have a good discussion with the administrative team at the hospital to get them to understand that too and help us do the things we need and get the technology we need to best support our patients. The first thing I'm going to look at real briefly is cholecystectomy because that's really the first model that we looked at. And what we noticed is when we started doing cholecystectomy, especially single-site cholecystectomy at the end of 2012, our gallbladder volume in that first year rose by 20 to 25% quarter for quarter for the year before. I assumed this would be great news. We're bringing in more patients. And when I presented that, this was the response from my CFO. It's exactly what he said. He said, we're going to go out of business that much faster because the one thing he was sure of, it was prohibitively expensive to do this kind of surgery. So I looked at it myself, and I looked at it because it's kind of at that point was me up against everyone else, right? Robotic procedures simply cost too much. And that was the dialogue back in 2014 when you sat down with any of the administrators of the hospital. And as I started to look at it, and as I started to go through the numbers, what I realized was this. In fact, I realized this as well. There are so many different numbers here, and there's so many different ways you can look at this that no one really has a good handle on exactly what these procedures cost. And the more I thought about it, we really can't get bogged down, and we can't really let them pin us down in the financial cost because that's not a realistic way to look at it. And as I told my CFO, we pay a huge electric bill every year, right? We turn the lights on, right? No one ever thought we should save money and turn the lights off and operate in the dark, right? It makes sense that we use the lights. So instead of looking at the financial cost, you have to shift the discussion to financial value. Everything we do has a cost. We want to focus on the financial value. I'm sure you can hear this repeatedly from multiple of the speakers as the morning and the day goes on. Track your data. I can't stress that enough. This is a data tracking spreadsheet that I set up years ago. It's cloud-based. It's actually on Google Docs now. It was originally an Excel sheet, and you can see I track docking time, consult time, total time, outpatient, length of stay, pain medicine, and so forth, complications. You can use this sheet, use your own sheet. Intuitive Surgical is just rolling out a hernia collection tool, which I think is going to be relatively easy to get over the next several weeks. However you do it, track your data, because at the end of the day, it's great to tell your hospital what you read in the literature. It's great to tell them what you heard here. It's great to tell them what's happening at my hospital, but they really want to hear what's happening at your hospital. So when we looked at robotic cholecystectomy, this is kind of what we found. A laparoscopic cholecystectomy at my hospital cost $1,000 in and out of the OR. That's the gowns, the gloves, the drapes, the sutures, that's everything. The first robotic cholecystectomy I did cost about $2,800. Now, to be fair, I used pretty much every grasper that was out there. I didn't know which ones I wanted to use. We really used a lot of instruments, but once we kind of pared it down, and this was single site, we're at about $1,250. That's it. Now, at that point in time, we were doing approximately 200 lap choles a year at my hospital. 200 times the extra $250, it's $50,000. That is how much it costs at my hospital. If we said we're going to do all our gallbladder surgeries every year laparoscopically, we're going to switch them to robotic, we're looking at $50,000 a year. Well, is there any value to that? So let's look at conversion to open, right? The published data is kind of all over, relatively straightforward, somewhere between 3 and 5%. At Northern Westchester Hospital, if you split that and take 4%, right, we're converting 4% of our cases. That would be 8 cases a year approximately. Again, we have at the top, we see the $50,000 what we spent. So if we have 6 to 8 cases converted, that's 3 to 5%. There's an OR cost to that. There's a wound complication. There's an inpatient admission that averages 3 to 5 days. $1,500 a day to be on the surgical ward times 4 days. That's $6,000 times the 8 patients, right? That's splitting the difference. That's the 4%. That's $48,000. So if we were able to reduce the conversion rate, there's certainly money to be saved. If we eliminated every one of those conversions, we're pretty much even. Now, I'm not suggesting we're going to eliminate all the conversions. I will say I've had one conversion in over 400 gallbladders now. But at the end of the day, some of that money is going to come back by the improved visualization, the improved instrumentation, allowing us to reduce the conversion rate. Bile duct injury rate, okay, this is some of the data out there. The bile duct injury rate, this is in lap chole, is approximately 0.6%, which interestingly is still almost double, if not a little more than double what it is in open cholecystectomy. Now, at Northern Westchester Hospital, if you took that 0.5% rate and we had 200 gallbladders per year, we'd estimate 1 injury per year. Again, that's the 0.5%. Actually, we have about 1 every 18 months at our hospital. We know why bile duct injuries happen, right? This is not the clip misfiring. It's a duct injury. It's a judgment error, right? The surgeon's making a mistake. You're misidentified the anatomy. Well, when you add in 3D visualization, depth perception, firefly, right? We can reduce, potentially, theoretically, the rate of injury. This is a bit of an abstract argument. I think it would take a huge series, to prove that one technique is better than the other, particularly because the occurrence rate is so low. The average medical cost of a common duct injury in the United States is approximately $93,000. 93,000 times that $250 a case, that's 372 patients, right? If we had one fewer duct injury over 372 patients, we're making some of that money back. So again, this is not the most mathematically rigid argument you can make, but this is how it started at our hospital. And we just looked at this, and when we sat down, our CEO and our CFO, they understood that. They understood that we've improved upon the technique and believed we'd be reducing injury rates and length of stay and conversion. So they understood at the very least, if they didn't believe these exact numbers, we would be saving money, and all that expenditure really wouldn't be just out the door. Incisional hernia, this operation right out of the box was cheaper to do robotically than it was to do laparoscopically, right? And the main deal there is in the absorbable tacks that we were using, right? For those of you who have an SI robot, don't have an XI yet, we compared. Over here you see the SI outcome, and here you see the XI, right? The total OR time, console time, suturing the defect, patch placement. Everything got better with the XI robot. And we're looking at a total savings of about 34 minutes per procedure. One of the nice things about the XI, because the arm carriages are a bit narrower, you can put the arms much wider, allowing you to sew on that near side of the patch. The key to that operation is really getting your trocars away from the midline, away from the patch, giving you as much space to work in. This is one of my favorite ones. This is inguinal hernias, and if you look at robotic inguinal hernias at our hospital, right, this is a laparoscopic TEP, the balloon dissector, the Hassan, the Sorbifix. And this is how I did it. I did about almost 2,000 laparoscopic TEPs in my career. It's a good operation. It cost us $865. The patch is not in here. I use the 3D Max patch, but that's going to be a wash because I still use that across the board, whether I did it laparoscopically or doing it robotic. And when I looked at the robotic case, accessory kit, I used the hook, the bipolar grasper, the needle driver. The accessory kit would be the arm drapes, the cannula seals, and so forth. And it cost me $900. It cost $35 more. And I had two separate thoughts, and I'm going to give them to you backwards. My second thought was, $35? I got to worry about that now? I mean, where does it end? Right? I understand we have to be financially conscious. I understand we can't waste thousands and even hundreds of dollars, but I have to start worrying about tens of dollars now? Do I have to worry about single dollars? Are we going to worry about loose change? I mean, really, where does it end? But if I'm totally honest, that was the second thing I thought. The first thing I thought was, man, if only it cost $35 less, I'd be up here screaming to everybody that we're going to be rich because we're going to save $35 a case. So a little hypocritical there, but the point is it's really almost cost neutral. But the fact of the matter is it's not cost neutral. It gets even better because the way I currently do it now, I'm only using 3 drapes. With an XI robot, you have to drape that 4th arm, and those arm drapes with all the little gearboxes and everything cost about $50. You can get rid of that $50 drape, and there's a sterile arm drape made. It fits perfectly. It costs about $7.50. You could even use a Mayo cover if you wanted to. I still use the hook. You can replace the bipolar grasp with the Cartier, and you're looking at about $780. So I can reduce the cost by about 10%. Compared to the way I was doing it laparoscopically. Now, there may be other ways, there may be cheaper ways to do it than this, and certainly if people are doing open, that may make a difference too. But at the end of the day, this is how I was doing it at my hospital. Nobody had a problem with that, right? I'm doing it cheaper now than I was then. This isn't really even the best part of my story. At my hospital, one of my colleagues preferred to do his hernias laparoscopic, single site, with a gel point. A gel point cost us about $600. His operation cost 40% more than my operation ever cost. And you know what the hospital said about that? Not a word. They don't care. They don't even know. Right? That's the problem with it. That's the hypocrisy. As soon as you talk about robotics, everybody gets all excited about it. Everybody knows that robotics cost too much. That was never the issue before. And even when we were doing robotics, this went on at my hospital for a long time. You'll be happy to know that surgeon does robotics now, so our hospital's not going to have to close. Real briefly on colectomy, and I'm going to talk more about this in a colon talk that I'm going to give a bit later on. This is just looking at the savings. These are my SI cases. This is XI plus ERAS, and this is the savings per case compared to all surgeons nationally. And we've saved the hospital $3 to $4 million by doing these cases robotically versus just the highest volume surgeons. We're not saving quite as much against the most experienced surgeons in the country, but we're still saving several millions of dollars. And again, I'll talk more about this in one of my colon talks I'm going to give later on. If you want to build a total practice and you want to build a successful program, the first thing you're going to do is find your allies, right? Allies in OR administration, allies in senior management at the hospital. Then work on efficiency, right? Build your team, find out which instruments you want to use, streamline it to the best that you can. Data, right? Collect your data. Again, I'm going to say that again and again. OR time, length of stay, conversions, complications. You want to understand how you're doing clinically, but this is how you're going to understand how you're doing financially as well. And then make your case. You'll probably hear about this a lot. We talk about the quadruple aim, and this is what we found. And by building a robotic program, and again, this isn't just being a robotic surgeon, this is a robotic program, our outcomes improved, right? Length of stay improved, the overall patient experience improved, right? We became more efficient, we became a better team. Everybody wants to be on the robotic team now. When this all started out, wasn't quite the case. And ultimately, we found that the cost of total care improved as we built our program. I appreciate everybody taking today for the talk. I'm certainly happy to answer any questions that anybody might have. Thanks so much.
Jerry, another great talk. I got to tell you, it's so funny to see your talk track on cost and my talk track on cost. It's almost the same talk, and we came to it independently. It's It's pretty great. So we've had some questions online, and some folks are in a community hospital. They don't have a robotics program going now, and they're wondering, how can I get that started? It's a difficult, daunting task to do that. You pointed out in your talk that there were organizational challenges that you faced at your program. What were maybe a couple of the toughest challenges, and what was your workaround towards getting the program going?
Yeah, thanks so much, DJ. You know, it's interesting because it is the similar experience to yours. And, you know, I hear Mike Stifelman talking about the similarities he sees. You know, we have much more in common, and there are so many more similarities amongst our programs and our hospitals. You know, I'm proud of our hospital. We have a great hospital and a great program, but I don't think there's anything unique to my hospital that's not really reproducible. And, you know, everyone who's here now is here because they appreciate and they're interested in growing their robotic experience and growing their robotic program and bringing it to more patients. I think that the two key things that I found from the very beginning is I had to find the right allies, you know, and as I said, it's really kind of a triumvirate. You need a senior level administrator. If you think, you know, the robot is the best thing since the scalpel to happen to surgeons, but your hospital's not on board, it's going to be frustrating. It's going to be cumbersome. It's not going to get done. So identify an administrator, you know, as someone who has enough clout to help you get things done and can help you through the financial issues and help you understand. And when you sit down and explain to them, you know, yes, this is going to cost us money, but here's the value in it. It's going to be better for our patients. It's going to be clinically beneficial. It's going to be financially beneficial. And then again, the third part of my team was a senior member of OR leadership, you know, to help us in the OR, building our teams, building our nursing teams, helping our turnovers, and identifying the right people to do that. You really have to do it as a team. And if you don't have a steering committee already, you know, set one up. I think Elisa made the comment, you know, there's a chairmanship waiting for you. You could be the chief of the division or the program. If you don't have one yet, then you're the one who needs to get it started at your hospital.
Great. Other thing, I know you referenced the administrators, and I have distinct memories of when I went to talk to my administrators about starting robotics and general surgery, and they're like, dude, way too expensive, right? We're not going to do that. And finally, I had data, and I was able to get that data, but I got to tell you, it was a real struggle to get data. They gave me, I thought I'd walk into my CFO's office and I'd say, hey, so-and-so, what is my lap chole versus my robotic chole cost? And I thought he'd go on his computer and boop, 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 and out would print the thing and say, here you go, here's the cost. And I was shocked that they had no clue how much anything cost. They were clueless as to the cost. They were clueless to how things work in the OR, honestly. It was a real eye-opener for me. But I love how you talked out your data to them. You talked about decreased length of stay, decreased conversions, decreased complications robotically. Do you think that was super impactful, and having that data was super impactful when you talked to them? Because that was a real game changer when I had data and when I came in to talk to them in 2013, whenever it was.
Yeah, I mean, you know, I was fortunate to the point that my hospital initially understood, you know, they believed what I was telling them, and some of my colleagues were telling them that this is clinically the right thing to do. And it really started with that. But had we not built the data, had we not collected it, because at the end of the day, the one thing my hospital cares the most about is how much things cost in my hospital, right? Showing them your experience and showing them what the literature says is only going to get you so far, because, you know, they are convinced, not even that it's close, right? They're not convinced that it's going to be close. They think we will go out of business. And that was the comment my CFO made. And that was really one of the eye-opening moments for me when he said that to me, when, you know, our volume went up and he said, we're going to go out of business. And I thought, you know, if I don't do the numbers, if I don't do it myself, it's not going to get done. So sitting down with a team of people, finding, you know, like-minded people in the different places in the hospital, and kind of building that. And again, you know, we're a small community hospital. I mean, I don't think that's a small point. We have 11 ORs and 3 XI robots. And if it wasn't for the data that we collected along the way, that never would have happened.
Wonderful. Great talk, Jerry. Thanks. It's so tough to talk about costs.